of aorta is an obstructive type of lesion of the acyanotic heart disease, and what happens in coarctation of aorta is that there's a juxta ductal position where it gets coarctated, that is just below the ductus arteriosus. Like also, see, just below the ductus arteriosus, which is about to become the ligamentum arteriosum, is when you will have the coarctation of aorta. Now what happens is that they also have CCF and claudication. Now if you check for the sounds, you'll have apex will be left atrial hypertrophy, so you'll have an heaving apical impulse, and the main thing is that they will be presenting with secondary hypertension. BP when the you'll have upper limb will be have more hypertension than that of the lower limb because of RAS activation, and lower limb is decreased, that is sometimes what happens is that they may even be weak and not felt only in case of coarctation of aorta. You can see a thrill in the left infraclavicular area, which is again at the same area of that of PDA. You'll have left ventricular hypertrophy because of coarctated aorta. All the blood go backs into the left ventricle. And X-ray you see an E sign in the barium swallow because of the notching. Also notching of the inferior ribs due to thickened intercostal arteries will be present. Now murmur, you'll have large systolic murmur. Anomaly, it's associated with aortic bicuspid valve and Turner syndrome. See, Turner syndrome, you'll have coarctation of aorta. A barium swallow, you see E sign, reverse 3 sign and all that. You give PGE1 analog to open the ductus arteriosus. Since it's constricted here, if you open them, it will be helpful. So you give for PGE1 analog. Surgery you do within 24 hours, excision and reanastomosis on day 1. And it's opened, reanastomosis is opened by balloon arterial dilation. That's it. In case of Takayasu arteriitis, you'll have upper limb absent pulses, and lower limb you'll have claudication. But here you'll have upper limb, you'll have increased BP. So that is the difference.